Welcome to the Codecast Podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast Podcast. My name is Terry Fletcher. I hope this finds everyone starting their week off well. And we are going to talk today about revenue integrity. So revenue integrity programs, I started reading up on this and really trying to grasp the definition of what's out there as far as an industry standard. And what I kept finding was just how this concept was only really feeding into the big corporations and, the companies that have 100 physicians and, that they can have this revenue cycle risk program and they have compliance officers and everything like that. And I'm not saying there's anything wrong with that. I mean, I love big corporations just like anybody else because that's part of my business as a consultant. But what about the little guy? What about the coder out there that says, I coded it right, I did this right, I submitted it correctly, I checked everything, and then you still get a denial code? What about that person that's out there saying, I just don't understand how to deal with some of this? So what I wanted to do is take that concept of revenue integrity and really look at different parts of it. So there's things such as coding and billing and charging and things like that. But let's just kind of dissect it a little bit. And I want to talk today about some denials that you get. So they're called claim adjustment denials. And it's a claim adjustment reason code, really, CARC. And then you get a number after it if you get a Medicare EOB or if you get any kind of a denial from another payer. And just tackle what you can do with some of those denials. And today I wanted to focus on possible place of service denials because I know we deal with that quite a bit. Shout out to Janet, who I know is a loyal listener of my podcast. And this is a topic that she asked me to tackle in one of our episodes. So I think we're going to try that today. But first, our Codecast podcast is also brought to you today by Medical Economics, Smarter Business, Better Patient Care, medicaleconomics.com. Now, if you couldn't tell, I've strained my voice this week. I have had 5 different webinars. I've taught a live seminar. I've recorded a couple of podcasts. So I'm definitely straining my voice. I don't know if you could tell I'm not sick. It's just at some point I need to just shut it down. And I think that's going to be tomorrow over the weekend. And so hopefully that'll work for me. But hopefully we'll get through it and I won't have too much issue. I have my water here. Well, you guys know me. I have my iced tea here. And we'll definitely get through some of the topics here. Also, in some of the conversations that I've had this week and just some of the things that I've been dealing with, my personal tidbit at the end is going to be basically a philosophical note that hopefully everybody will take to heart on just some things that have come up, not just for me personally, but just things in general that I'm seeing out there in the world that I just hope that everyone will appreciate some of the words I may speak on that. Today is also International Women's Day. I'm actually recording on a Friday before the weekend. And so for everybody that listens, I know you'd be surprised. We are not just recording or I should say broadcasting from where I'm at in Southern California. We have several countries that also listen into the Codecast podcast. As I just pulled up my stats, we're at 41,661 listeners. And we have our geography here. We have so many countries here that are listening in. It looks like 56 countries in total. So from everywhere from Finland, United Kingdom, Germany, India, Puerto Rico, Canada, Ireland. Shout out to my Irish kinfolk out there, Kenya, Switzerland, Sri Lanka, Hungary. So that was a new one that just came up. And Saudi Arabia, Austria, and anybody I missed. So thank you again for listening and happy International Women's Day for anybody that is listening in that is not in the United States. So we appreciate you. Okay, so let's get into our topic today. And when we look at this topic, it's amazing what's out there. So when we're talking about place of service, physicians are required to report the place of service, and the acronym is POS, on all health insurance claims they submit to Medicare Part B contractors. The POS, or place of service code, is used to identify where the procedure is furnished. Physicians are paid for services according to the Medicare Physician Fee Schedule, another acronym for you, MPFS. This schedule is based on a payment system that has three major categories. And this is what drives the reimbursement for the physician services. So practice expense, and that reflects overhead costs involved in providing the service, especially if it's in the office, physician work, and then malpractice insurance. So to account for the increased practice expense physicians incur by performing services in their office, Medicare reimburses physicians higher amount for services performed in their office, place of service code 11, than in the outpatient hospital, which would be place of service 22 or 23, or in an ambulatory surgery center, POS 24, or inpatient, POS 25. So that's why it's really important to know the place of service, because it plays such an important factor in how you get paid and your reimbursement. So in saying that, just a little cautionary tale here. So for professional claims, you want to make sure that you keep informed on Medicare coverage and billing requirements. So for example, billing physician office POS 11 for a minor surgical procedure that is actually performed in a hospital outpatient department, POS 22, and collecting a higher payment is inappropriate billing and could be viewed as a false claim or program abuse. So you want to keep in mind that there is a list and instructions that CMS has in their publication 100-04, Chapter 26, Section 10.5 at the cms.gov, and that really gives you some information as far as place of service. So now let's take a look at a direct bulletin from what Medicare says. And so Medicare has implemented something called the Hospital Outpatient Prospective Payment System, and it's OPPS is the acronym. It was established in 2001, and it was required by the Social Security Act. And what it does is it identifies those services that could safely be provided to Medicare patients in the outpatient setting of a hospital, initially considered a stay of less than 24 hours. So for services and procedures that were identified as inpatient only, CMS or Medicare created an inpatient only list that is updated annually also in this OPPS final rule, and it's published every November 1st of each year. And you can find that in the bulletin at the cms.gov website. So what is that inpatient only list? So what that is that refers to procedures and services that Medicare or CMS, when I say CMS, I mean Medicare, I mean the same thing, has identified as typically only provided in the inpatient setting and not paid under an outpatient prospective payment system. So many of the services on the inpatient list only are surgical procedures that are probably complex, complicated, and require the care and coordinated services provided in the inpatient setting of a hospital. And so it's important that surgeons be aware of the procedures that are on that list, because again, your impact to reimbursement is going to be huge on this. Now, does this list change? Yes. So each year, clinicians, specialty societies, other stakeholders contact CMS to request that procedures identified by CPT codes be reviewed and considered for addition to or removal from the inpatient only list. Okay, since the inception of the outpatient payment perspective, some hospital stays have extended beyond 24 hours and up to 48 hours. And also remember, medical technology has improved over the years, and coordination of care has improved across different clinical settings. And so some of the inpatient services have now been kind of changed to an outpatient situation, and so they get removed from the inpatient list. But when considering whether to add or remove a procedure from that inpatient list, Medicare first considers the type of the procedure or service being performed, whether the procedure is safely being performed on non-Medicare patients in the outpatient setting, which when I think about that, I think, okay, so commercial patients are guinea pigs, that's weird, and whether any published data on outcomes is available to help in the decision-making process. So what they're looking for is, okay, is the patient readmitted? What is their likelihood of getting readmitted or having to have another follow-up surgery because something isn't working? And then, will I get paid if I perform a procedure in the outpatient setting if it's on the inpatient list? So this is a pretty big deal, and I think this is what one of our listeners was concerned with, because I know that she was saying she was getting a denial on place of service issues. So a physician who performs an inpatient-only list procedure in the outpatient setting of a hospital may receive payment if the documentation for the procedure meets requirements for medical necessity. The hospital, however, won't get paid. And so subsequently, hospitals will often have someone from the quality or case management team review the medical record early in the patient's stay to figure out the appropriateness of the admission and assess whether or not medical necessity for inpatient care is supported. This is why you remember the 2 midnight rule that we're having to deal with. Does the patient need to be in the hospital longer than a 24-hour stay? The American College of Surgeons also reviews the procedures on the inpatient list on an annual basis, and they make recommendations to CMS regarding those procedures. Can they be removed on the list without compromising patient safety or quality? And the ACS also comments against proposed removal of procedures from the list, and changes to the inpatient list is basically updated every year. And one of the ones that I was really surprised at that it got taken off the inpatient list, and that was the total knee, total joint. So the 27447, that was removed from inpatient status only. So was a laparoscopic hernia, paraesophageal hernia repair with fundoplasty, a gastric restrictive procedure, so the gastric device component, a lot of laparoscopic services. One that was added, and this kind of speaks to one of my specialties, and that was the percutaneous coronary intervention of a patient that had an acute heart attack. So that was actually on an outpatient list, because typically during a heart attack, if they go ahead and put in a stent and do an angioplasty and get that vessel better, that patient almost always can go home in less than 24 hours. Or at least 48, but this was added to the inpatient-only rule because what was probably found was that these patients needed that extra day to let their body just calm down and heal a little bit from the procedure. Now, you would think that these lists only affect the physician, but they don't. They affect the patient because few people are aware that Medicare has established a list of surgeries that will be covered by Medicare Part A, and the patient, when they're in a Medicare Part A coverage situation, their out-of-pocket is a lot less and the hospital absorbs a little bit more. But if there is no complication and the person undergoing surgery does not have significant chronic conditions that could put them at risk for complications, these are when they default to Medicare Part B, which is possibly outpatient or shorter stays in the hospital. And that's going to affect how much the patient also pays out of pocket, because now they're going back to copays and deductibles under the Part B situation. So in that list, just a couple, just to give you an idea of what you'd be looking at. The surgeries are not arbitrarily selected. So they're really due to the complexity of the procedure, the risk for complications, the need for postoperative monitoring, and anticipated prolonged time for recovery. And so they're really a high level of care. So a couple of things on the list that I'm looking at: coronary artery bypass grafting, also known as a CABG, a gastric bypass surgery, heart valve repair or valve replacement, colon colectomy surgeries, total hip replacements. So what was interesting when I mentioned the total knee replacement, I just thought that was really just a change, because I've seen that done so often in outpatient. But now that's considered, or it's an inpatient, now it's considered an outpatient. So that means no longer covered under Part A, they're now considered Part B. So for the safety of Medicare beneficiaries, inpatient-only surgeries must be performed in a hospital setting. And that's when that Part A covers the majority of the surgical costs. But the out-of-pocket for the patient goes up on an outpatient perspective when you still provide it, possibly in a hospital or ASC, but it's not paid as an inpatient service. A couple of other surgeries that fall now on the ASC or outpatient list this also is referred to as Addendum AA on the Medicare's website. They also call them same-day surgery centers as well. So it means that under the guideline, the surgical codes that are included on the ASC list or outpatient list of covered surgical procedures are those that have been determined to pose no significant safety risk to Medicare beneficiaries when furnished in ASCs, and that are not expected to require active medical monitoring at midnight the day of where the surgical procedure is performed. So they're saying that they don't necessarily need an overnight stay for safety, such as cataract removal, colonoscopy with or without biopsies, epidural injections for back pain, prostate biopsy, shockwave therapy. So those are under Part B, and the patient will be required to pay their 20% coinsurance, and also any kind of anesthesia out of pocket, IV therapy, all that. There's quite a bit of services that almost far exceed the Part A deductible. And so that's where it can be kind of a problem when we're dealing with just patient out of pocket on these services. So it's just something that, it's a collaborative effort by physicians and AMA and Medicare, and how they feel about, is this appropriate when it comes to patient safety, and where should that patient have their surgery? And they don't really take into effect, well, this is going to cause them, kind of a burden on their out of pocket. They just look at from a standpoint, do they need to be in the hospital with all the, interdisciplinary staff there in case there's a problem, or can this be done at a more relaxed outpatient setting? And the outpatient setting is so much less expensive and less cost to the Medicare payers. So for them, they're looking at cost, but as far as to the Medicare beneficiary, they're not. Now, there's one other piece to this that I just want you to keep in mind when it comes to making sure that you're understanding these denials on place of service. It's not just about what's on the list, but also understanding if the hospital, if that's where you build your service, and then your claim form, making sure that you have consistency in the place of service. So if you get a denial, and it's usually CARC code 05 saying that the place of service doesn't match or is invalid, it doesn't just mean that you weren't on the list, okay? What it can mean is that the hospital has it as inpatient, you have it as outpatient, or vice versa. A lot of times it's vice versa. And so they're not consistent. And the facility and the physician have to be consistent in their place of service reporting for every party to get paid. So one will get denials, and just so you know, the facility actually trumps the physician. So they're going to want to know that. So that's the first thing you're going to want to do when you get that kind of denial, is check with the hospital or the facility where you build it and find out what place of service did they use, and then see if it matches yours. And then after that, if you both use the same place of service, then you go to the list and say, okay, was this an outpatient service, or was this an inpatient-only service that's on a list that we try to bill as outpatient, and it basically didn't work? So those are the things you want to really look at when you're dealing with POS and the issues there. Okay, so a couple of things have come up recently, and I want to address that in my coding question. So there is a website called ZocDoc, ZocDoc.com, and it will allow the patient, refer patients to it. It allows them to check their insurance coverage, find out if they're PPO, EPO, HMO, whatever managed care, and it lets them know if they've got coverage for their specific policy for screening, for and what their deductibles could be, and then what their complete share of costs could be. So I really like this website. It's amazing how we have now just really some places to go for the patient that isn't always tied to just their own personal insurance or their own personal insurance company's website. There's actually collective websites out there that are free that will put the information up for anybody to be able to see it. So refer them. Again, that would be ZocDoc.com. So my coding question today comes from a subscriber in Kansas City, Missouri, and it is on the 59 modifier. And the question was, so Terry, we've been using the 59 modifier and we're having some issues with it, and I'm not sure if you can help resolve it, but we're trying to figure out how to get this modifier to, pay us what's necessary. And here's the situation. So we had a patient that had a left heart cath with intervention, and we put a 59 modifier on the heart catheterization after the 26 modifier, just like you've told us, and we're having a hard time. And so we're not sure, we're getting a lot of denials on our cardiac cath. So what do we do? And so here is something that, and I know that obviously we say to protect it because there's a CCI edit, meaning that when performed with an intervention, you're going to have an edit on the heart cath. But remember, you also have those subset modifier options of the 59, which means those X modifiers. And they are there to selectively identify distinct procedural services, even as a more descriptive type service. And so let's say that you did what we call a cath possible. So patient goes in, they're scheduled only for the cardiac catheterization. They've got chest pain, shortness of breath, something's going on. And now your physician says, you know what, due to this information, so after they do the heart cath and they get angiographic data, they said this demonstrated, therefore we're going to proceed with. And then let's say they do a stent to the right coronary, 92928 RC. Well, the 93458, which is the cath code with a 26 modifier, it may be more appropriate if it's a Medicare patient to put the XU modifier on. So again, that's a subset modifier of the 59. And it says unusual, non-overlapping service, the use of a service that is distinct because it does not overlap the usual components of the main service. And that's why, heart cath intervention are bundled, because a lot of times physicians are going in with the catheter and just injecting the coronary so that they can set up for the intervention. And that's not billable. You've heard me say before, it has to be diagnostic. And so instead of the 59, you would use the XU in that scenario for a Medicare patient. And then just looking at the rest of the X modifiers, the XP, that's a separate practitioner, a service that is distinct because it was performed by a different practitioner and a different practitioner within the same group. So keep that in mind. XS is separate structure, a service that is distinct because it was performed on a separate organ structure. And that gets messed up all the time. Everybody's trying to code for that with different territories in the legs, but let's face it, you're still in the leg. It's when you have a completely separate service that has nothing to do with the primary service. And then XE, separate encounter. I really like this modifier. Consider in gastroenterology, where you have a patient that had a colonoscopy by snare in the morning, 45385, and then they were put on observation before they went home just to make sure everything's okay, their outputs are good. And then it's determined, let's say, 8 hours later that they're having a spontaneous bleed. Maybe something is, because there was a scope in their colon tract. So now they have to go back in and cauterize that area. And it is a separate encounter. So at a different time, you went back to the endoscopy lab. And so let's say that you did a 45382 and then, control of bleeding, that would be an XE modifier. If you just put the 59 on that, that would reflect that you were in the same encounter, just a different service. And that particular service is not covered during another primary service within the colonoscopy or endoscopy payment rules. And so those X modifiers are really important to look at. If you haven't seen the one-time notification of it, pull it up on the Medicare's website. It is Change Request 8863. It came out in August 2014, effective January 1st, 2015, and it's transmittal 1422. And it's just a one-time publication. But here's some data that just came out you might be interested in. So in 2017, when X modifiers were really prevalent, there were a lot back then, they appeared in 5.4 million claims were submitted to Medicare. The overall denial rate was 17%, which I thought was crazy because that's actually a really good percentage, and it's usually because of wrong use of the modifier. But when you look at just the 59 modifier with a 41% denial rate, this X modifiers have made an impact on getting claims paid. So the rate for XU was 23% errors, XP 18%, XE and SX were a bit worse at 12 and 4%, but it's interesting just noticing that these are taking away from the high denial rate of the 59 if used correctly. So do your due diligence, make sure you understand how to use them. Make sure you attend my modifiers webinar that we will have in April, and it goes over all the modifiers with examples explaining to you how to use them and how to make sure that you're accurate, because modifiers are your key to reimbursement. And so you need to be mindful of how to use that. We also have our HCC, our hierarchy chronic condition codes webinars, coming up on March 12th, part 1, March 14th, part 2, and then we'll have part 3 and 4, how to calculate your RAF score in April. So hopefully you're signing up for that. That's had a lot of positive there. And a reminder that in April, we will have the virtual visits or telehealth webinar on April 16th, and Incident 2, which we're talking about the mid-level providers, how to code and how to document for nurse practitioners, PAs, clinical nurse specialists, etc. That'll be on April 17th. And today's coding question was brought to you by Orion Health, revolutionizing global healthcare so every individual receives the perfect care for them. Join the revolution, orionhealth.com. Okay, so ending this week with my personal tidbit. So this has been a week of reflection for me, just dealing with some personalities and some people that have been important in your life, but then at some point you basically need to consider, when you're having a bad week or a bad month, and this is something I just want you to think about, take a minute to look around you. Are you surrounding yourself with people and situations that build you up or only make you feel bad about who you are? And if it's the latter, consider removing those things, people or obstacles, out of your life. People always say to me, life's too short, but in reality, life is long. And it's so long that we just don't want to continue to have people in our life that are not positive influences, that don't make us feel good about who we are. So we need people in our lives that are there for us, understand who we are and what we need, and how we can they can inspire us and we can inspire them and make for some happy moments. So do not waste your time. And again, it is your time on people and things that make you feel less than you should. And as I like to say, if they don't have your back, move on. So hopefully you'll understand what's going on with that this week. Just to have a different mindset, and hopefully everybody will make it a positive. And head into this weekend, we are going to be moving our clocks forward. Let's see, spring forward, yes, fall back. So, or I should say a little bit later in the morning now. So it's not going to come in my room at 6 o'clock. So it'll be a little bit later in the morning, and we'll be getting a little bit more light at the end of the day. So everyone, make it a great day. And until next week, thanks for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.